Hello, everyone. Thank you for attending today's webinar, Health at Home, the New Normal of Care, presented by CareCentrix. I'm Rebecca Williamson. I'm the publisher of Fierce Healthcare, and I'll be moderating this webinar. Our speakers today are Melissa Carr, General Manager of Home Health Solutions at CareCentrix, and Jon Terenzetti, Vice President of Advanced Data Labs, also at CareCentrix. You can read their full bios by selecting the Speakers tab on the left side of your window. I have just a few technical notes for you before we begin. If you'd like to download the slide deck, please click the Handouts tab on the left side of your screen. This webcast is being streamed through your computer. There's no dial-in number. For the best audio quality, please make sure that your volume is all the way up. The webinar is being recorded and will be available on demand within 24 hours after the event. And time permitting, we're going to follow the presentation to the Q&A session, so please submit your questions using the Q&A tab on the left side of your screen. All right, that's everything from me. Melissa, please go ahead.
Thank you, Rebecca. Good afternoon or good morning, depending on where you are in the country. Jon and I are very excited to be here today and talking about why health and aging in the home has never been more important than it is now, during and post the COVID-19 pandemic. So what we'll provide an overview of today is one, just kind of establishing an overview just of kind of what was the current situation before COVID, and then two, what have we learned from COVID? What has accelerated? What type of innovations have taken place as we scrambled to get our most vulnerable patients actually into the home, as staying in the acute settings was suddenly more dangerous for them than ever before. Then we'll take you through some examples of some innovations that we've implemented since COVID-19, really kind of accelerating the way that we're providing monitoring in the home and the different types of technologies that we're leveraging to interact with patients on a day-to-day basis. And then what's the future? How does this change healthcare? How does this change the industry? How does it change the way we need to be thinking about solutions to really provide the best patient-provider experience while also lowering the total cost of care? So we'll talk about I think one of the things that have really been just amplified in the last several months is just how fragile our healthcare system is. And when the world we live in at CareCentrix is very focused on the post-acute realm. So we're really focused on what happens to a patient as they're leaving a hospital, as they transition to, a skilled nursing facility, a long-term care facility, or if they're driving care to the home. And how do we identify which is the right care setting for each individual patient, and then manage the transition and the coordination from one service to the next. And we feel that this is so important because the whole healthcare system is incredibly fragmented. When you think about when a patient is leaving a hospital, there's inadequate communications. There's not a way to really share information on what the next best care setting could be for that patient. There's minimal sharing of patient information. And unfortunately, to date, there's been a lot of misaligned incentives through the continuum so that we can actually have the care and coordination to have a connected and holistic patient experience. And, as an industry, we could be doing so much more if we better leverage tools, technology, innovation to really drive how we interact and provide care. When you think about it, we force patients to actually go to the settings to receive care versus having the care come to them. A lot of that can be done through communication, the advances in video technology, and obviously we'll be talking a lot about that the post-COVID world has totally changed the adoption of telemedicine, and again, making us think about telemedicine in a completely different way than we have in the past. And that's just one example of how we can start bringing more and more of the care to the home, and that it's safe and that you can have very effective communications with patients leveraging those types of channels versus the face-to-face when you combine telemedicine with remote monitoring. The physician has a lot of the information right at their fingertips that they would have if they were seeing you face to face. And in fact, a lot of times the information that you see in the home can tell physician, give them cues that they would never otherwise see in terms of your living arrangements and what other non-clinical support really might be best to keep a patient, healing in the home, aging in the home, and preventing readmissions. So the other big issue that we've seen is that reimbursement and regulation have not always been favorable to a modern approach. People have said for years, I could definitely do a lot of these things, but I'm not going to get reimbursed for it, so why would I bother? It's really, again, hindered a lot of the innovations that can be done from a telemedicine perspective. And especially, again, in our world, we focus a lot on home health. There was absolutely nothing out there in terms of reimbursement for those types of programs. So if the future of care is home, what do we need to be doing differently to really take care of all acuity of patients in the home? What are the right combinations of digital engagement, remote monitoring? How do we have systems where we're better able to communicate upstream to the physicians and to the hospitals at discharge planning that, going to home health agency A versus going to home health agency B is going to be better for that patient who is coming out with a hip replacement because that facility is so much better able to work and has better quality outcomes related to their care, their way that they're offering that care and their services versus if I have, I need a wound specialist, then, healthcare provider, home health agency B would be a better provider for those types of services. So how do we create more coordination end-to-end through the system to really provide the best transitions of care to patients from the very day they're leaving the hospital and get them the care they need to really leverage the home as the site of healing and aging. So with that, I'll turn it over to Jon to talk a little bit more about how we're embracing this new era of technology.
Thanks, Melissa. As Melissa mentioned, we really are entering a new era in which technology is going to transform the way we think about healthcare and, in particular, the way we think about delivering care in the home. I really like this image of the iceberg that you're seeing on the screen here because I think this is a very accurate representation of where we are today. The tip of the iceberg, the things you can see, are kind of what you've experienced in a traditional healthcare setting, in a hospital, in a nursing facility, et cetera. The area under the surface is really the new opportunity and new kind of realm of technologies that are going to transform the way that healthcare is delivered in the home and each and every day if people are able to take more of a kind of patient-driven and data-driven approach to providing care. So what is driving this change at this point? I'll save the obvious for last because COVID-19 and the coronavirus pandemic has certainly created kind of a new sense of urgency around a lot of these trends. But in large part, a lot of the building blocks for the delivery of more comprehensive and better care at home as enabled by technology has been underway for a number of years. Really, the first item that I think is often overlooked, but it's critically important to this development, is really that the price of technology has decreased while computing power has grown exponentially. We're now at a time in which we are able to access computers, at the tip of our fingers or via remote monitoring or any type of wearable device that is far more powerful than the best computers that existed 20 years ago. And it's actually a really interesting study around why healthcare is now embracing technology at a greater rate, because healthcare is distributed. It requires a significant number of data elements and touch points, and therefore requires technology to be available at scale at a cost that facilitates real democratization of data. If you think about kind of where technology was at say the birth of the personal computer. And think about what that means in terms of the increased ability to access technology. I think you'll see really what we're talking about. I recently came across a very interesting Best Buy study, which it looked at advertisements that came from Best Buy in 1994 and compared them to those in 2016. And one of the comparisons that was most interesting to me was that a laptop in 1994 cost over $3,000, $3,225. And today, a laptop that has 1,400 times more hard disk space and 2,000 times more memory is for sale for only 20% of that cost, $650. So I know that this is a slightly different application. It's personal computing versus healthcare technology, but goes to speak to the fact that we are in an age in which extremely powerful machines are available in a variety of places in all the devices we're using on a daily basis and can be used to most effectively deliver care in the most decentralized setting that exists, the home. The second item that is very critical is new reimbursement mechanisms that are providing payment for home technology. As Melissa mentioned, there have been a significant number of shifts in reimbursement patterns, and what that means for not just reimbursing the healthcare that we know and have experienced in the past, but also reimbursing for healthcare that we know is going to drive better outcomes in the future. With the expansion, for example, of supplemental benefits launched by CMS at the beginning of 2020, and reimbursement available for things such as telehealth and remote monitoring, and a number of social determinant or non-clinical barrier to care elements such as transportation and food, we're entering a new era in which what is right is now also possible because we are able to be reimbursed for delivering this care. We are now able to set up effective telemonitoring and telehealth solutions and have that still kind of drive the cost needs of the system while also enabling the home and so many of these other additional benefits to be something that is very real and tangible. The third item is that patients are adapting to technology in all parts of their lives, and they expect it in healthcare. If you think about an industry that is potentially not loved by the American public, it's healthcare. In a recent study of net promoter scores, kind of the percentage of patients who would recommend your company or your institution as compared to those who would detract from its reputation or speak against it, healthcare had the lowest proportion of positive net promoter scores. It's even lower than transportation and banking. And you know how upset you get if ever your flight is delayed or canceled or whenever you have to go to the bank. So, people have experienced healthcare in a very negative way in the recent past. And now that we've seen what technology has done in other realms, we expect a life that is more seamless and more tailored and is more bespoke, delivered to us without us having to go through so much inconvenience. In an era in which we no longer get in our cars, drive to the movie rental store, hope that the person before us had rewound the videotape, we just expect that content will be available on demand on our TV or our tablet. We don't want to be waiting in a taxi queue in the rain so that we can get to our destination. We expect to know via Uber or any other similar app that car is 3 minutes away and will arrive at your destination at a certain amount of time for a certain cost. That type of consistency and ability to really tailor the experience is something that we've become accustomed to in so many parts of our lives. And we're really now beginning to embrace and expect, frankly, that healthcare is going to provide the same type of service. If I can text with anyone, why do I need to pick up the phone and call to reschedule a doctor's appointment? And finally, the fourth key factor and the true kind of catalyst and accelerant for a number of these trends is COVID-19 pandemic. For so long, healthcare has been able to be too expensive, be too cumbersome, not drive the right outcomes, and not have kind of, frankly, the engagement of, regulators or from the public around the reasons it needed to change. With COVID-19, the idea of healthcare being delivered at home is no longer a luxury, it's a necessity. When you're dealing with the true health and safety of an entire population, so many of the walls that have been built and so many of the regulations that have been in place begin to really shift away. And that's also an important element of how we're thinking about the non-clinical barriers as well. We know that, for example, it's very helpful to get inside a patient's home and do an assessment and see, if there is a rug that is out of place that could cause a frail patient to fall. Something as simple as that is accelerated by the understanding that as patients are going to be, in large part, expecting more care to be delivered at home, there are many elements about their living environment that can provide clues into how better to deliver care and how best to reduce the likelihood of an acute or emergent episode. Melissa, I'll pass it back to you to talk more kind of specifically about our COVID-19 learnings.
Sure. And I think, as we talk about COVID-19 learnings, this is really around what our initial response to COVID-19 has been at CareCentrix, and is really just kind of, as we go forward, I think the full impact of what it's going to mean for us in our business, as well as every other aspect of healthcare, is still really being designed. And there is going to be huge changes in the types of programs and offerings that are available to payers, really around driving care to the home and what that looks like for very different conditions. But when when COVID-19 first hit and there started to be hot spots coming up throughout, the United States, New York, New Orleans, Detroit, everywhere across the country, we rapidly saw that we had a couple of issues when you look at our business model, right? One, we're working to get patients discharged and help to do, skilled nursing facility management and or get patients to the home. So right away, you start seeing there's this huge issue with getting any patient who else does not have to be in the hospital out of the hospital. And how do we make sure we're sharing that information of who could go home? And if they can go home, what what services do they need to, both to the point Jon made, clinical, non-clinical needs? What are the right wrapper of services we need to make sure are available in that home so that patient can heal and doesn't have to be re-hospitalized? We also saw that access, when we provide home health services, all of a sudden we had to think about how to work with our home health agencies very differently. All of a sudden there was an access issue for them as well. They saw issues in terms of patients not wanting to have someone come into their home because they were afraid that they could be a carrier, or the availability of nurses suddenly was less than it had been because the nurses didn't want to go into the homes, or all of a sudden now the nurse is doing homeschooling with 3 children and it doesn't have the capability to work. So there's a huge impact on the workforce. So we saw all of these different access issues that we really needed to make sure that we had some solutions around. And then within our readmissions program, we have our nurse coaches who are support. How do we need to think about that model differently? All of a sudden, we're getting on the phone with patients who have very different questions, incredibly different concerns than they had weeks before. So as we really set about, our core of enabling care at the home, we took multiple approaches to, how we changed our business model to really support these new needs. So again, in the past, our model, you think about, well, you really only need to engage with the riskier patients. Again, that changed. Every patient who's leaving a hospital in a post-COVID-19 environment has concerns, has different questions. So we made sure we made that support available holistically. We created, within less than like a week, we created a home health telemedicine benefit and platform. Again, going back to those reimbursement structures, we didn't have a way prior to this to reimburse we didn't have the mechanism to reimburse our home health agency providers or our durable medical equipment providers for leveraging telemedicine. So we had to get that up and running, create a whole, payment mechanism so that we could work with our health plans and we can make the telehealth platform available to their patients as an alternative to having someone come in for that in-person visit. So now, you could have a nurse visit done virtually. We've seen great success with, physical therapy, speech therapy, occupational therapy, where they were able to continue to engage with those patients and provide them care and service in a very safe way during this time, and with a huge quality component still associated with it. The nurse coaches ensured members receive information to the point around clinical and non-clinical needs. What we have seen a lot of is obviously the need for transportation had gone down, but suddenly, these people who were used to having meals delivered to them and could get out for meals or someone could take them out for dinner are suddenly not able to do so, and they're not able to cook for themselves. So we have seen a huge increase in the number of our patients who need meal support to be delivered into their home. And, the other last thing is just depression, social isolation. The behavioral impacts of COVID-19 are going to be one of the many things that there's going to be a lot of attention to and is not going to go away. The effects of it are going to be far-reaching for a long time. So being able to just check in on the patients and know that we're there to talk to them, we're there to relieve any anxiety has been hugely important. And, the other part of that is being able to address their questions was just really making sure our staff was fully trained to address COVID-19 concerns, fully updated each day. I'm sure as many payer organizations are doing, basically kind of like, war room debriefing every day, changes, making sure sharing of information so we can make the latest and greatest information available to our patients and their caregivers. And then really, just kind of trying to ensure we were always listening to what was going on with our provider network, what was going on with the home health agencies, where were we seeing that there were issues of getting patients with care, what were the concerns around, treating COVID patients, and how do we make sure that everybody had the right equipment to do so. So just been really the importance of just really consistent monitoring and communications to make sure all the latest and greatest information is leveraged so that we could continue to be flexible and enhance our response as we've gone through it. And, now we're monitoring to see where things go next. Are there going to be resurgence in any markets? We know this changes each and every day with the direction of what it can take. So we have to continue our best practices that have been enabled here so that we can be ready for whatever is the next step. And speaking of next steps, I think that will be a good transition. Jon, back to you to tell us what that future will look like.
Great. Thanks, Melissa. I think one of the most important things you said was that, in the era of COVID-19, every patient needs care, not just the riskiest. And I think that is one of the key changes and one of the key outcomes of this situation that is going to be one of the most powerful on the future of healthcare at home and health technology at home. I think in many ways, this pandemic has driven what I'm now referring to as the democratization of healthcare. We know that the weakest link in the chain, so long as one person can get ill as part of a pandemic like this, the entire system can fall apart. And so we know now as a society that healthcare can't just be for the most determined or persistent patient. It has to be for all patients. And doing that involves an understanding of the ways to tier and segment care, leverage cheaper technology to provide more baseline services for a greater number of people, and do more from a system that has historically been more expensive and driven poorer outcomes than in other places in the world. So this experience, I think, in a lot of ways, when coupled with technology, is going to radically change the way the future looks. And it won't just be the excited woman in this slide experiencing this virtual reality. As we move to kind of the next slide and think about the future of care at home, there's really kind of three major trends that we're seeing at CareCentrix based on our experience that we believe will continue to be hallmarks of what the future looks like. The first is really early identification of patient decline. As I mentioned, we need to find ways to provide insights to a greater number of patients and their well-being more easily than is done today. So many ways in which that can be done are driven by technology. If we think about, for example, wearables or the ability to monitor a patient's ADLs and vitals on a more frequent basis, we will be able to spot trends associated before that patient even can. You know, patients and people generally experience things as individuals and therefore may have a harder time contextualizing and understanding when a certain experience is really indicative of a larger change in their healthcare. And so by leveraging technology to collect those mass amounts of data, by leveraging trend analysis to understand that when a patient with X condition and Y comorbidities experiences Z change in temperature over a certain period of time, we know that's indicative of an emergent risk and is a place where we need to intervene in a way that the patient may not understand and may therefore wait until that emergency has occurred to seek help, at which point it may be too late to prevent kind of that emergent illness. The second is kind of this easy communication between patients and providers, in particular using the technology to which we've become accustomed in daily life. The idea of chatting with your doctor is not new. It has just been historically extremely cumbersome and unenjoyable because you have to remember to go to a portal and what's your password and what's your username and how does it work? And it doesn't fit into the way that we are living our lives. And so much of kind of making healthcare more accessible and more, frankly, successful in the delivery of positive outcomes in a post-COVID world involves meeting people where they are and ensuring that we can communicate effectively to them based on that reality. And then finally, the third kind of key bucket is certainly the idea that we will be developing and launching platforms that support the delivery of higher acuity services in the home. As Melissa kind of mentioned earlier, in many ways, telehealth and remote monitoring, for example, can replace less acute doctor's visits in a large portion of cases, those in-person visits, because what they can do is allow your doctor to ask you the questions, to engage with you, and have all the vitals they would have collected in their office. So as we think about what the future means, patients who are sick no longer just need to go to a nursing facility. They can go home with the associated care resources and technology that give providers a continued view into what's happening in their daily lives. And so what COVID has done is exposed, in a lot of cases, the most acute patients shouldn't be going to facilities because of underlying conditions and other risks. And if that's the case, how do we rethink what the home means, not just to deliver, less acute services, but also for patients with the greatest need who will be able to be bolstered and supported by technology to receive a greater portion of services in the comfort of their own home. Melissa, pass it back over to you.
Thanks, Jon. And, a lot of what Jon was, mentioning about wearables and, how do we make the home for especially those higher acuity patients, how do we make it safe? We have to ensure that we have a toolkit of remote monitoring services and a way to collect that information and to make that information actionable to better care for those patients who have more severe illnesses, and to intervene on a much more real-time basis when we see that there may be some sort of emerging need for the patient, and then get them the right care proactively, versus waiting for them to, not having any type of communication with them, and then they get more severe, they don't have those things, those actions taken, there isn't an intervention, and they end up back into the hospital, which again is what we're all trying to avoid. So one of the things that we've been doing is really, again, it's a combination of how we make sure that we are collecting information about the patient. And one of the things that we've implemented, and this was planned before COVID, but it's become so much more important as a result of it, is how we leverage the information that is collected during those home health visits. And we bring that in from every time, a nurse, a physical therapist is in the home, and how we collect that information from within the home to identify what is really the current situation for that patient, how are they doing against a number of factors, and then take that information and not only just look at it real time, but also look at it longitudinally, leveraging some AI and predictive analytics to determine that a patient has emerging risk, that again, we need to have a different level of either care case management, we need to get them coordinate different additional services in the home, we need to get an interaction or get a televisit with a physician to really understand what's going on with that patient and determine what is the next path or how to actually adjust their care pathway. So you see here, some of the great information that we get just by looking at what's in that home is, we understand more about their setting, their well-being, including their mental health. The importance of behavioral, again, is going to be paramount as we go forward in making sure there is different levels of accessibility to different behavioral health utilities, and as they move forward, making sure people have access to that level of care is going to be critically important. And then, when you look at the activities of daily living, is that patient actually going to be okay in their home dressing and grooming and bathing, or do we need to get a home health aide or a personal care assistant into the home to assist with them? And then really moving on to more of the interventions. Fall risk is very common, and it's a very easy thing to address if you know that it's a problem. So this gives us the dynamics to be able to do that within the home. And then really identifying when a patient is in need to transition to a different level of care. Are they so ill or in that trajectory that we should be considering a move into, palliative care or hospice? So really fully leveraging this information in the home for all patients. We're also, working in certain instances to ensure that we have iPads available for both either the patient or their caregiver, so they can be giving us information and doing quick real-time services. We're looking at, other solutions where we can be just a quick check-in with a wearable for us to get more information around that patient's condition, and again, then drive the necessary impacts to their care plan, leveraging the whole care community to ensure that patient really has the best chance to stay in the home and avoid that hospital visit. And the second component to that is once you understand what's going on with a patient, you have to have an effective way to communicate with them. And, there is not a one-size-fits-all approach. We need to have a multimodal approach for how we can be communicating with patients. And again, how we ensure that we give them access to care. Leveraging telemedicine for nursing and for therapy, really does ensure that we can get access to care for even the patients within the most rural areas. It ensures that we can better leverage limited resources like wound specialists, where there can be someone in the home and they can be consulting with that other nurse through a video conference versus having to actually send them to these very disparate places. So it gives us a different care model that very much, when you have the right combinations of services, can be personalized for the really individual needs of each and every patient and their family setting. It enables us to start, bringing the family in. So now I can be part of a home health visit with my mother in North Carolina when I'm sitting in my home in New Jersey. Just the way we're able to share that information has been really critical and will continue to be something that we do a lot of work with refining around, in the near future. And it will constantly be evolving. It will never be great. It will always be a work in progress. But we've really found, with COVID and really being able to leverage telehealth or video chatting with a nurse has been incredibly successful with our patients. Since we've launched that, we've been doing our Net Promoter Scores and our patient satisfaction surveys. Really wanted to monitor that closely to ensure the quality of the service that is being provided is just as strong from a telehealth perspective as it would be with an in-person visit. And not only have we seen patients across all ages ranges be willing and accepting of trying the technology, but we've seen that they've had really great results. We have a Net Promoter Score of 75, which is higher than in some instances we see for in-person visits, patient satisfaction of 95%. So when we do it and we're able to do it well, you can have incredibly successful experiences that can be used not only for the visit, but also to augment communications between visits. Again, how we continue to collect information just as simple as a daily check-in, via text message. How are you today? Good. The impacts of social isolation, just knowing someone is actually there who's going to be reaching out to you, we've seen just has such a tremendous impact on these patients and their experiences. So I'm going to pass it back to Jon to talk about what other things do we need to think about as we have these higher acuity patients that we want to keep in the home.
Thanks, Melissa. One of the really exciting things about the trends we're talking through here that we haven't touched on in a ton of detail on this call is the fact that this is creating an incredible amount of data, the true definition of big data around what patients are experiencing in their daily lives so that we can best understand what their risk looks like, what they will respond to appropriately, where they are most likely to fall down in their healthcare experiences and endeavors, and then how we best support as we deliver an increasing number of more acute services in the home. One of the things that we have done at CareCentrix is invest significantly in building the infrastructure that allows us to capture and trend data around exactly what has happened historically with a large number of patients. And then from there, what do we think that means in terms of our prediction of how best we can engage with and manage our patient population? And through the creation of this database, which has over 10 billion claims and 100 million patient discharges, as well as new and emerging data sets around ADLs, vitals, social determinants of health information, clinical assessments, we're able to get an incredibly rich vision of what the patient has experienced and how they will likely react to a number of interventions. And as the number of services that shifts toward home increases, we think even before COVID-19, the executive order around the movement of kidney care services from dialysis centers to the home, conversations around SNFs at home and hospital at home, and delivering a much greater number of services at home. So much of that will be bolstered by data, by an understanding of the correct trends and correct intervention approaches, and also by all of the tools that Melissa mentioned in terms of remote monitoring, telehealth, et cetera. The future of higher acuity care at home is going to be one in which patient risk is assessed differently. It's not just that this is a challenging procedure, it needs to be done in a hospital, or this is a an easy thing to heal from, so therefore go home. It's a combination of understanding risk and severity, but also understanding that in a time in which, infection is prevalent and, airborne illness is a real threat to our society and our daily life, we need to be thinking differently about what high and low acuity services mean and how they can be delivered in the hospital, in the nursing facility, in a rehab center, or in the home. And so the COVID-19 pandemic has really accelerated, but also raised a lot of additional questions around what it means to be shifting more care at home and how best to think about the services that make the most sense for each individual patient. Now I'll pass it back to Melissa for some final thoughts before we jump into questions.
Well, I definitely want to hear your final thoughts as well, Jon. But, I think that what we have seen with COVID is it's almost going to have that Amazon effect on healthcare, right? It's going to forever change the way that we interact with the healthcare system, going to change the whole paradigm of healthcare and what it means. Things that we've talked a lot about as an industry in terms of, skilled nursing, SNF at home, or hospital at home suddenly becomes so much more real. And you can think in the future, 5 to 10 years down the road, that our home and actually having our surgeon come to our homes to do some routine surgeries will be the norm. And how do we create a world where that happens? How we create a world where those most vulnerable patients can actually stay home and have the right care coordinated for them to minimize their needs to go back into a hospital setting. I'm not exactly sure what it all is going to look like or how all the different blocks are going to come into place, but I know it will forever be fundamentally changed. And I've never been more excited to be in the line of work that we are so we can help design that future.
Absolutely. And I think my final thought on top of that, Melissa, is exactly as you've said. The building blocks for this movement have been in place for a while. And this situation has really been the catalyst that I think will continue to push a greater amount of healthcare, not just to a place that is safer, but is also a place that is more comfortable and the preference of the majority of patients. There must be a silver lining around every cloud, and in the era of COVID-19, the greater delivery of care in the comfort and safety of home, I think, is one of the most valuable lessons and changes that will come, and it will be supported by technology, an understanding of how data identifies real patient needs, and by an overall system that has obviously gone through trauma and best understands at this point how to deliver care in a new setting. So thanks so much.
All right, great. Well, I think it's time to move on to Q&A. Again, thank you for the great presentation so far. I want to remind all of our audience members there is still time to submit your questions. You can use that Q&A tab on the left side of your screen. We have a lot of great questions. We're going to try to get to as many as we can. So first question that I'll ask of you two. So some have suggested that it is uncertain if current reimbursement changes as a result of COVID-19 will stick or remain in their current form. What are your thoughts on this?
I think it's going to be a little bit all over the place. There will definitely be fundamentally, I think, on the telemedicine side when it comes to like physician and more traditional kind of telemedicine for access to nursing and physician care. I think that's going to be really, really hard for that to get rolled back. So I anticipate some of those changes will be more likely to stay. Some of the other impacts and some of the other kind of loosening of regulations, I do think that those things will come back into the norm, but how quickly, obviously the jury's kind of still out. On the home health side, we're seeing plans are getting very creative, and a lot of plans are now even just starting to work that this like home health telemedicine visit or benefit type thing, they're working that into their plan designs for the future. So I can't say that's going to be across the board, but I start to think that there'll be people starting to be more creative of how they can actually offer the services and be reimbursed for them a lot. And I think the supplemental, but on the Medicare Advantage side, I think that's where they have the most ability to really try to leverage that as part of a supplemental benefit support. So it will change. It just, I think some will happen more quickly than others. I know, Jon, if you have any additional thoughts there.
Yeah, I mean, so I would totally agree. I think that the great news is that, as Melissa mentioned with the supplemental benefit side, a lot of the changes in reimbursement had already gone through. I mean, we're already in effect by the time that COVID-19 hit. In large part, though, there hadn't been as great of an uptick as many folks in the industry had expected, likely because there just wasn't as much visibility into what they were, or patients weren't demanding them. And I think now, certainly, patients have gotten a taste of how helpful a number of these services are, and will continue to push for them to be included in the benefits that they are signing up for in the future.
Okay, very good. Next question for you. What would company landscape look like for healthcare at home? Talking about health companies, pharma, tech, others.
All of the above. It really is going to be, you can't have one single one of those services by itself won't solve for the needs. So it's really going to be a concert and coordination between those different organizations to really best enable the care in the home setting. Pharma is a very interesting one. For years, they've kind of been like, I don't care where the patients are receiving my medications as long as they're receiving them. And we work a lot, in the home infusion space, so we really can talk about it in the biopharma space. They've always been pretty agnostic about it. Now all of a sudden we have them clamoring to work with us of how we can create programs and offerings to really drive infusions in the home when clinically appropriate. So I think that's one just very quick change that we saw, and I think that's something that is going to get a lot more momentum over time. But I don't think, again, it can't just be solved for by one thing. It's going to be who can best provide the coordination around the home health, the durable medical equipment, the infusion services, getting the drugs, and all those support mechanisms supported by the technology in the home.
Absolutely. I think that I can't think of a time when the entire country has been focused on a single critical healthcare need as much as they have during the COVID-19 pandemic. And what it's forcing people to do is really think holistically about the landscape and understand that there is an interplay between pharma and testing and hospitals and physicians and illness and all of those components and how they fit together. And so I think, to Melissa's point, the landscape will be forever changed. And in many ways, I think it will emerge as a more collaborative and a more cooperative one, because we know that the solution can't come from one of those groups alone.
All right. With the rise of telemedicine, do you ever see traditional in-home healthcare and/or nursing going away?
No. There'll always be a place for where you really need to have somebody in the home. You think about some of the more severe patients, or really sick kids and people with severe health issues. They're going to need somebody face-to-face who can provide the care. Certain instances, there are limitations with physical therapy based on certain types of conditions where they would still really benefit from having that care in the home. So I don't think it goes away. I think that it becomes a beautiful stuff. I think the best model when it comes to home health and providing nursing and therapy services in the home is the combination of telemedicine and in-home. I think it really is those two together that can provide the best care model. I also think it's going to be critical, being in the home to a lot of what we talked about in terms of what are truly those non-clinical support needs of the patient. Without getting in the home, it's very hard to fully address that home situation and identify what additional services that patient could benefit from.
All right. Now, many elderly people have significant challenges using unfamiliar technologies. How can the home care industry overcome that?
It's interesting. Again, you won't crack every nut, but we've seen just even through our implementation of the telemedicine is we've seen people, 90-year-old patients who for the first time ever used FaceTime or connected for a video chat, had never used it. We had our teams actually had to sit there and talk to them, found out they have, do you have an iPhone or do you have a mobile phone? And yes, and does it have this feature? Yes, and walk them through it. And then, did a quick conversation with them and said, okay, would you be comfortable having a nursing appointment like this? And she said yes. And then when we called for a follow-up for that patient, she said that not only did she think it was such a great way for her to have her physical therapy, but she was actually going to do a virtual call with her neurologist later in the week because she wasn't able to get into the office for a visit. Again, that's an N of one. But I think that it's forced different decisions. And so people who in the past were unwilling or didn't really have a reason to take the leap, this is going to take the movement. The other thing I would say is the role of the caregivers. Just because that patient isn't comfortable with the technology, do they have, is an elderly patient living with one of their children who could help them with that technology? So again, we'll never solve for all of it, but I think that a lot of the barriers, you just have to be creative with the way that you can really introduce the patients to the technology, take that extra time with those upfront steps of making sure they understand how to work it and be comfortable. And then following up and say, did it work? And figuring out very quickly if it's not working for the patient so that they can actually get the care they need in the home. Another example of that is where it wasn't working is we have another patient who was very elderly, very hard of hearing. So he kept missing his telemedicine appointments, his nursing appointments via video because he couldn't hear the phone ring. And he actually ended up getting admitted back into the hospital, and we were looking why he was admitted into the hospital, and we realized he was missing those nursing visits because the phone. So, that was one very quickly. Telemedicine doesn't work. So again, it's really introducing it to the technology, making sure they're comfortable using it, and following up very quickly to see if it's working or not. At least that's where we have what we've seen successful to date.
Sure, absolutely. All right, I think we've got time for one or two more questions. So we'll ask this question here. How do home healthcare companies address staff training if higher acuity services are introduced?
Yeah, it's very interesting. And this is where we do not think one home health agency is ever created equal. And there's, some of the more innovative ones that we work with are already thinking ahead and have done a lot of work and have put a lot of investment into technology and starting to think through the training of their patients and picking a couple of conditions that they really want to focus on so they can build the right support models around it. So I think that's what you're going to see as we move forward is what certain home health agencies are going to want to do is going to be more customized. They may not want to be great at everything. They may want to be better and really strong in a couple of areas of competency, which will allow them to then make sure that their staff are hyper-focused on those needs of those higher acuity patients and have the right tools available to them, as well as greater access to, supporting PAs, nurse practitioners, physicians, et cetera, so they can have a more kind of coordinated approach with all levels of who may be necessary to provide that clinical care.
All right, very good. I think that's all the time that we have. Again, we had a lot of really great questions. We couldn't get to them all, but we want to let you know that we'll try our best to get back to everyone who submitted personally after the webinar. So I want to thank you all for attending this Fierce webinar, again, and submitting so many great questions. I really want to thank our speakers for participating and CareCentrix for presenting. The webinar has been recorded. You'll be able to access this within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining us, and we look forward to seeing you at future events.